This is my first episode being behind the plinth, so welcome to everybody. Welcome, Lachlan.
Thanks, mate. Good to be here.
Yes. So we thought we'd do this series about the ACL or anterior cruciate ligament. Both Lachlan and I are passionate about trying to help people with this injury because it is one of probably the worst sporting injuries that you can sustain. I'm sure you would agree.
Absolutely. Yep. About that.
So we're going to go sort of answer in this sort of episode 4 main questions. And the first question is, so, putting you as you're an athlete or you're a parent, you've got a child or you have torn your ACL. So, like, what happens next? You've torn your ACL.
Yep.
What's going to happen from in the next sort of 1 month of your life?
Yep, for sure. No, great question, mate. And look, to get a bit of a preface or understanding of what to go into that process of that 1 month post you're tearing your ACLs, I guess to actually know what is the ACL and what's its purpose, I guess. So got a knee model here. It's a bit hard to see probably on the camera, but if we remove the patella, you can see right here we have, if you probably can't see too far on here, we've got the ACL ligament here, okay? So it attaches to the top of the femur here, all right, where your thigh sits, and then attaches also distally into your tibia or your shin bone, okay? And its purpose is to prevent that forward translation of your tibia and also rotational movements as well. And in other words, give it really important for knee stability, okay? And often if that's compromised, can have a significant amount of pain, significant instability, usually immediately post-tear, inability to be able to walk on your leg properly. Okay, you get a lot of swelling as well, which we do see, and I think that's the most important thing during that initial period of when you have torn your ACL is trying to get swelling under control. We find that if swelling persists, range of movement won't be able to return as quickly, and therefore can delay rehab processes even further. Right?
Yep.
So, I guess when obviously you consult a physio if you do suspect you have torn your ACL, whether it's playing sport or during work or whatever that may be. You can also go see your GP if either the physio or GP suspects of a ACL. We do certain tests obviously to determine that. We do try and send you for a MRI, or we will send you for an MRI because that's the gold standard of that diagnosing of the ACL. Yep. Then after that, depending on certain outcomes, which we can go into, I guess, but you go talk about whether we're going to go surgically to manage it or that conservative route, mate. Yep. So if you want to go into more specifics there.
Yeah, so there's a lot of, so traditionally in the last 20 years, the non-surgical approach has probably been less talked about. However, now the non-surgical approach is being talked about a lot more. And I don't think that any one person can tell you what the absolute right thing to do is, because it's case by case basis. But the big issue too around your ACL tears or ACL rupture is the associated damage that happens. So if we might just talk through, and Locke might show on this on the model here, but things like tibial plateau issues, so that is like the top of the tibia. So for a younger child, like an adolescent, the issue with that is a growth plate is the top of the tibia, like an epiphyseal plate it's called. And if you have damage to that, then that can extend the time frame of the injury and it can make the pain quite a lot worse. And then you have meniscus, so that's the cushiony bits in between the two bones there. Now, there's some evidence of doing a review of ACL prevention programs at the moment, and one of the things that they talk about in the research is the percentage of people that progress to early onset osteoarthritis. So it's around that 50 to even 70% of people within 10 years are showing signs of osteoarthritis after having an ACL tear or surgery. And so the fashion, or not the fashion, but the trend now is to repair meniscus wherever possible. However, in our experience in the rehabilitation side, that means that the rehabilitation is going to be slower in the first 6 months because when you stitch a meniscus in general, it takes a bit longer to heal. And some of the surgeons that we work with are very are very strong in that. So you might hear, if you go and see your surgeon, they'll talk about they're going to repair the meniscus, and you have to be careful about loading the knee, which is impact, running, walking long distances. You have to be careful on that for a while because they're stitching the cushioning part of your knee back together, but it doesn't have very good blood supply. And so muscles have the best blood supply, tendons have slightly less, ligaments have little compared to muscle. And so there's reasons behind that, but we won't go into that right now. But the most important thing for you to know, if you've torn your ACL, is that the ligament healing or the meniscus healing process is much slower than a muscle.
Yeah, absolutely.
Would you agree?
Yeah, absolutely. Especially say you have gone through the surgery, and usually the new graft, whether it's a hamstring graft or patella graft or allograft, we'll get into a bit more detail, but it's usually at its strongest immediately post-surgery, but then it actually weakens over time, especially within 6 to 10 weeks post-surgery, because that revascularization period or that blood supply that's we're trying to return to the ACL, it takes a long time. There is little to none, and therefore that graft will not degenerate, but it'll get weaker, it'll get a little bit looser, and that's why we do need to be very, very careful, and we have those protocols in place like during that rehab, and it's not like your MCL where you hand me back into that 6 weeks. It does take your 9 to 12 month process there.
So I guess, the next question we were going to talk about is what can you expect from an ACL injury rehab, and that kind of leads into what we've already started to talk about. So me personally, after doing a number of them now, I, for people that have been coached by me, maybe regard as somewhat of a control freak or whatever you want to call it. So in ACL rehab, I think that's kind of important in that first stage. So I'm quite prescriptive on what I want people to do, especially when I'm getting them back into exercise. So in that, let's say you've torn your ACL, what can you expect from a physiotherapist in those first couple of sessions, so that you know what you're expecting?
Yep. Big thing early is education, obviously, and trying to be very transparent with the patient, whoever that may be, and trying to get their goals. So not every ACL patient that I've had is wanting to get back to sports. Some are just looking to get back to work, and it's a low impact job, so those goals do vary. But say from a physio perspective, if I'm seeing an athlete and they're looking to get back, we are educating on the fact that it can be that 9-12 month process, especially more so the 12 months if it is someone that's younger. Okay, so also assessing things like your swelling management, going through that, doing your ice, your elevation, trying to get that swelling pretty much eradicated as quickly as possible. Also looking at range of movement, trying to improve that so that we can then progress to strength-based work as quickly as possible as well. So that's something we'll address in the first couple of weeks. Obviously, again, with that, blood supply still, taking its time, we do take things very slowly, okay? So the exercises that we might go through in that first 2 weeks post-surgery are, whilst important, they're pretty boring, I'll be honest with you. They're pretty straightforward. And so, unfortunately, though, it is what needs to be done in order to progress to the next stage. And if we're not meeting those goals, it's increasing the risk of re-rupture rates there. Yep. So a lot of education, and then but very basic range of movement and strengthening exercises, really. And
I think a really interesting post that was made by Mick Hughes, who's one of Australia's, or arguably probably one of the best physios in Australia at the moment, doing ACL injury prevention and rehabilitation. He talked about returning to running on a swollen knee, and if you're trying to do that right now and you've got a swollen knee, go and read his post. Go find it. It's pretty easy to find. And shout out to Mick, because I've followed a lot of his work, and he's put out the Melbourne ACL guide, which we use in our own practice. But the big thing to expect is teenagers or adolescents will catastrophize the injury much worse than an adult. And obviously there's reasons for that, in that they don't know what to expect. I mean, you're looking at 12 months for a teenager. Remember, if you're a parent, 12 months is an incredibly long time. So jobs for you as an athlete, I try and give people little jobs. And then, so if I'm looking at someone from a global perspective, what to expect out of an ACL rehab, one of the things that's probably my favourite thing to say is, well, there's a chance to fix all the issues and to correct all the patterns that you had prior to the injury. And I'm going to try and make you a great athlete from all of those issues, because now we have the time. And we didn't have the time before because you were doing your 50 million training sessions a month, and we didn't have time to do that. But now I do. I'm going to help you create yourself, a better body for sport. So you've got to find ways to drive that competitive nature to be better, because then we've got a job to do as an athlete. And I know from my own point of view, that's what I would want as an athlete. Like it is very, very systematic, and you could argue boring to do the first even 6 months. So I think that's where the physiotherapy and the strength and conditioning sort of model can work really well together. In that we'll look at the global, and someone like Lachlan's looking at the specific, like what are we doing, week to week. Whereas I'm like, okay, what are we going to turn you into? I picture in my mind, 12 months time, this is going to be you. And that's sort of what I might have in my mind when I'm starting to look at like getting you back in the gym. But I can't stress enough, the first 2 weeks, either post-injury or post-surgery, your job is to let your body heal itself.
Absolutely.
It's not to go and swing yourself on crutches and try and do 1 million push-ups a day and try and make all the changes then. Your job at that point is to get yourself and let your body heal and do whatever the surgeon, whatever the physio says to do, and do it when they say to do it, because they've done it bucket loads of times before, and we know how to do it. There's so much research on this particular topic.
Yep, absolutely. Well said.
Well, so how or why do they happen?
Yes. Great question.
So let's look at some of the mechanisms over the last 5 years. So mechanism. Walking over to pick up a ball, bending down.
Yep.
There goes an ACL. Like, how does that possibly happen?
Yep.
So, like in your experience and looking at research, like what are some of the key mechanisms, and maybe we might even change the behind the plinth and get out in front and show people some of the angles. But what are some of the angles that we look at?
Yeah, so great question, Glenn. So look, a few things, especially with athletes, not just that bending, also like you need that quick change of direction. Okay, we do see that non-contact sort of injury. You usually know pretty straight. So what happens is basically, with an ACL, we call it shear force, okay? So when the change of direction occurs, okay, the tibia will go one way, the femur will go the other way, okay? And that's because that's the two attachment sites of the ACL, okay? Because that creates that shear force, that's when the tear occurs, okay? So angles that we look at, obviously, so we call it knee valgus, okay? So in other words, that when, again, we might demonstrate probably if it is, but when we're squatting, for just as an example, if our knee goes, Glenn's gonna get it. Oh, here we go.
We'll turn the camera and we'll
all right, we'll get into
show
it.
you some angles.
Yeah, that might be a bit better.
So,
I was just going to say this is called knee valgus. So an example you can really see in a squat. Okay, Glenn's going to demonstrate it here.
If we do a single leg activity here, so we want to have a straight line between your hip, your knee, and your foot. Mm-hmm. So when you do your ACL, it's classically this. So we rotate this way, and then this rotates again. So it's called a pivot shift injury. Mm-hmm. So we've got that sort of cut, and then that, and then we've done an ACL in that direction. Yep. And you can see them a lot of the time in the mechanisms on the TV when they happen in sport. And the other one is like just a pure hyperextension injury where you're getting that shear force across, which is what Locke's talking about as well. But in general, what we look for when we're trying to prevent these is like that force loading through here and then pushing like that, so that we're pushing force through this angle here. So we're getting that like sort of direction this way, like inwards towards the inside of your body of the knee. And under force loading. Yep,
absolutely. And it's important to, like with our rehab, that we're not just doing it in that squatting position, because, well, that's our baseline, but, when you, especially at return to sport, you need to be running, you need to be changing direction. So often, again, like when we're going that like footy step, for example, you go that change of direction, the knee goes in, femur wants to go the other way, there's that shear force. We need to retrain that knee, hips, foot are all aligned, so that when we do change that direction, it's that less shear force occurring on the ACL. So that's why we'll do a lot of single leg stuff, a lot of plyometric work, whilst keeping that alignment there. Yeah, for sure.
All right.
Back behind the plinth.
Yes, absolutely. All right. So that just gives you a bit of an understanding of what we look at post and why it happens. So 70% of ACL injuries happen in non-contact situations, which means you haven't been contacted by anything or anyone else, and your ACL has ruptured or torn when you were running, stepping, stopping, jumping, and landing. So those sort of non-contact situations. So that lends the researchers to think that there is ways to prevent it. It would be slightly more difficult to prevent the contact-based injuries where you are twisted in a terrible shape.
Of course.
I think we'd all agree with that.
Yeah, absolutely, mate.
So then the other thing is female athletes versus male athletes.
Yes.
So let's talk about this quickly. But it's 2 to 8 times more likely if you're a female athlete to rupture your ACL or to tear your ACL than if you're a male athlete. And that's in relative terms. Male athletes still have more ACL total injuries, but with the rise in contact and females playing contact sport and running, court and field sports, being especially the football codes, this is something that we are working really hard with, especially in my sort of realm at the moment, to try and focus on preventing them. So, and that's probably a chat for maybe later on today or maybe another time. But preventing them, there's 50 to 60% likelihood of preventing an ACL from doing 20 minutes of work 2 to 3 times a week. So that is worth doing. If it was 5%, I'm not sure whether I would sell it as hard as I do, but 50 to 60% is worth doing. So then probably the last question is, can you prevent an ACL? Well, the answer is in the research. It's, probably read between 40 and 50 research papers focusing on injury prevention programs of ACL in adolescents recently. And I've read some adult papers as well, and it's very, very dominant. It's 50 to 60% across a wide range of papers that have said, this really works. What are your thoughts, mate?
Yeah, no, definitely you can't. There is clear evidence to suggest that prevention is more than possible. And what I like about it too, with the research that's coming out, is the exercises to attain that prevention. They're not difficult and they're not time consuming, as you said. 20 to 30 minutes. Then they're pretty generally basic strength exercise. You don't need to be in a gym. You can do them at home. You can do them, warming up prior to your sport. So, absolutely, it's exciting and it's great research, but still more needs to be done, though. Obviously, if we can get that number even higher, great, but still 50 to 60% to avoid injury or re-rupture. Just from doing that, it's definitely worth it, that's for sure.
So, just to go through some basic structures of what you should do. So, I looked at lots and lots of prevention studies. So, the most dominant theme is strengthening, balance or proprioception or neuromuscular training, and then plyometric training. They're the most dominant of how to prevent an ACL injury. So, for example, this would be an example thing that you could start doing as long as you do it well. And then the other critical factor is the supervision technique feedback. In a lot of the studies, is a dominant factor as well. So that made a difference in the researcher's opinion. So, for example, being able to perform a good lunge pattern. So starting with a static, then progressing to a dynamic, then like clock or multi-directional lunges, tolerating different ranges of motion in a strengthening pattern. Trying to progress to any sort of single leg squat pattern without valgus. So you might start in a balance supported mode with like a lunge pattern into a single leg squat. Nordics. So for anyone that doesn't know what they are, we might publish some videos of some of the exercises after this, but Nordics are dominant in the research in terms of creating hamstring strength. Any sort of glute exercises are seen to be positive, so whether it starts with a glute bridge, it can be done on the ground, you can use mini bands. And then plyometrics. So plyometrics are a wide range, so any landing control-based exercise to start with. The plus side of all this is that you become a better athlete from preventing an ACL. So if you can perform a good lunge pattern, good single leg squat pattern, a good Nordic pattern, they're some of your key lower body strength exercises that we'd want to see in a normal gym program. So, for example, if you're already doing the gym work, then you could probably argue that you could just do a generalised warm-up with the plyometric loading twice a week on grass in a court or a field-based sport, and you've covered a lot of your ACL benefits. So I wouldn't suggest that that say you're going to send an athlete to the gym twice a week and then you're going to do another 2 strength and then plyometric sessions. With a younger athlete, you may end up just making them sore. So if they're already in the gym, you take them out of the strength work and you just put them in the plyometrics. The plyometrics vary quite widely. So I know I value how it's done, like every day more than just doing the work. So if I can get 2 to 3 really good sets at a time out of somebody, I value that over just plundering through like 10 sets. And I'm sure, you know, anyone that's done this sort of thing would agree.
Absolutely.
So things like a double leg jump, you know, landing without valgus, double leg jump, then progressing to a single leg landing, progressing to any sort of contact base, so contact in the air, distracting you with a ball, distracting you with an object like a hurdle, progressing that just generalised motor skill pathway along. So if you're a coach, pick 3 plyometric exercises, do 2 to 3 sets of every exercise, you know, 6 to 10 contacts on the ground each exercise, and progress that along from double leg work into single leg work by the end of a season. And you're doing your athletes a significant favour. And only progress your athletes when they're demonstrating competency. So might mean that half your team in an adolescent team are doing single leg work and half are still doing double leg work. But with 50 to 60% results, it's really something that should be done by every single coach of every single, at least adolescents. And then into adulthood, well, the athletes should be responsible enough to do it themselves. But I know that it's boring and I know it's not exciting, but after having to have so many discussions now with athletes, parents, support people, family, about, hey, I'm really sorry, but this is most likely going to take 6 to 18 months for you to be back to full athletic, you know, prowess. The big question that I want to finish on is, can you afford to have 12 months off?
No, exactly right. And I think the big thing, with like that 12 months off, then that usually really hits home with them in particular. Like if they, you know, whether it's going to work, whether it's, you know, or for athletes, you know, if they're cutting corners, if they're going it too short, they're going too early with it. I often add this on, okay, if you can't do it, well then, what about another 12 months after that? And another 12 months, because at the end of the day, if you're cutting those corners, the re-rupture rate is significantly increased, and that's why. And usually it hits home. Sometimes for some, they take a little bit of extra prodding, a little bit of extra reinforcement. But again, you got to make that message very clear. Otherwise, that's when things can go. Or another thing I'll just quickly add, you did touch on it with the strength stuff. I do see commonly around that 6, even probably 4 to 6 months, you know, it's getting boring, but, you know, they're getting stronger, they're getting a bit more confident, they start loading more, okay, even outside of recommendations. And all of a sudden they come in, you know, one week and my knee's really sore and they freak out, you know, have I hurt my knee again? And we test it all, and usually, most of the time it's all fine. The reason that pain is aggravating is due to overloading, okay, so it is important to know with ACLs, especially for teenagers who just after surgery, they see their quads deteriorate. They want to smash quads. They want to really get their quads, but it's not just a quad strengthening based rehab. Glenn touched on it before. You've got to strengthen it. Gluteal function is so important, especially for that reduction in valgus, because if that's not happening, no matter how strong your quads are, you're not eliminating that mechanism of injury to prevent re-rupture. Okay, so that's why, yes, the work is boring, but we've got to target everything so that way we can get you back on the field within that time frame required. So just, a little tip I see all the time. Yep, absolutely.
So I think to finish, let's just look at your top 3 things. If you're looking at this and you've just had a rupture and we've just taken you through a bit of a life cycle, if you're sitting there right now, so what are the things, well, let's just rehash swelling management, because you talked about that before. Let's just look at what you would ask someone to do right now if they've torn their ACL.
Okay, so I would ask them rest immediately, okay, so obviously no running, but like trying to minimise even walking as much as you can, okay, icing, 20 minutes on, 20 minutes off, doing that regularly throughout the day, okay, elevation as well. Compression, the new research is a little bit more 50-50 now, but like I still find for some people it is helpful. So I do recommend it still. Okay, even though I do understand the research is not as prominent as it was back 10, 15 years ago. So I have found good benefits with some patients there. That's why I don't. Again, we are research based, but at the same time, if someone goes, I feel so much better, especially early on, and that means they'll comply more, then absolutely, we'll get compression on. So ice compression, elevate, rest, or your RICE therapy, essentially. Critical in that first week alone, and staying off your feet as much as we said before. Body needs to rest, because if you're walking on that with swelling, it's going to delay your rehab. It's going to even if it's prior to surgery, we need to prehab it as best as we can so you can have even better outcomes post-surgery. So that's the main thing I'm talking about with swelling. Yeah.
Well, again, if anyone has any questions, more than welcome to contact us. We do understand it is a very hard injury to both have and then to rehabilitate due to the time. So for people out there that are currently working through ACL rehab, props up to you, because we know that it's tough, but persistence, patience, that will get you the rewards, and just doing the little things at a really little things well at a really high level will make rehab work long term more than likely. And what I love about here, especially at Vector Health, other than just the physiotherapy on my side of it, we've got the strength and conditioning, the exercise physiology. We have a great team that can combat and work together throughout that 12-month period if it takes to meet those goals that you require. So thanks Glenn, appreciate it. Thanks, podcast. Good to do it. Thanks. Thank you.
Awesome.